In today's video, you will learn all about EPA's common misconceptions, whether an EPA is really an EPA, and how best to transition to EPAs so you can be successful in this domain. Let's talk about holistic success. Hi everyone, I'm Anju and welcome to this episode of our Holistic Success Show. Our channel is dedicated to looking at all aspects of holistic success within higher education. Here with me today is Sylvia Mioduszewska.
You got it, Anju.
Thank you. Who leads product management for our 145 program management solution. Sylvia works closely with our partners to develop 145 further and knows the ins and outs of program management in health sciences. She talks to hundreds of our clients and partners from time to time, and to get input to really understand their landscape. So today she's here to talk to us about EPAs and provide some great insights for program admins in this area. Welcome, Sylvia. Would you like to say hello to our audiences?
Yeah, hello, everybody. Really excited to be here chatting with you today.
That's awesome. It's so great to have you here as well, Sylvia. So let's get started. My first question to you, Sylvia, is what is EPA?
All right, so I think the EPA itself, it stands for Entrustable Professional Activity. And these are tasks or responsibilities that can be entrusted to a medical trainee to do on their own once they've demonstrated sufficient competence. They're a bridge between the classroom and clinical practice, and they're a practical framework for assessing a trainee's residence for independent practice, or even just performing the tasks of residency if they're an undergrad. They're designed to be observable and measurable, and they're often integrated into multiple competencies. And the competency piece is the critical piece of the explanation, because EPAs are one facet of competency-based medical education, or if we think about it in terms of the wider landscape, competency-based education training, which can be applied to almost any profession. And so, as I mentioned, EPAs can be used across any training program, any job, including here at Acuity. In fact, I suggested an entrustment framework for our own performance reviews. And it's one thing I really used to explain, what entrustment was. In any role when you're starting, you can say, I needed to be there to watch you to do the thing, and now I know you can do it on your own. And that can be valuable, whether it's, in the operating room or the kitchen. And think about entrusting your teenager with being able to, use the air fryer or something else.
Oh, that is such a great way of putting it. So really it is about, here are the things you need to know to be able to do something. And are you there? Are you there yet? Do you have that
Yeah.
competency? Yeah.
Yeah. Did you do all the things that I expect you to do in this scenario in order for me to feel confident to leave you alone to do this? And I think when you think back to the underpinnings of competency-based education and training to the 70s, it really was a much wider landscape. And medical education's really run with it in terms of what they've done with competency-based education. But there really is this idea where it really is all about, can you perform the tasks of whatever discipline, of whatever thing you need to do on your own.
Yes, but it's used a lot in medical education and also some other healthcare education, which is absolutely phenomenal because we do need our medical professionals
Yes.
and health professionals to be able to do what we believe they can do. So, okay, thank you for explaining that, Sylvia. So, what are some of the most common or problematic misconceptions that you've encountered with EPAs?
Oh, that's a great question. I think the biggest misconception is equating EPAs with competencies and using those interchangeably. While competencies are the skills or the knowledge that's needed, EPAs are the actual tasks that integrate all those competencies. So in medical education, there's a number of, competency frameworks. They all, and frankly, in all health professions, they're really kind of similar. There's ideas around medical knowledge and collaboration and, systems-based practice and all those things. Those are the competencies. But the EPAs are the actual tasks, like taking a history, for example. And so when you conflate the two, I think you're essentially providing a different set of information that you might be intending to. So we often see programs assessing competencies and aligning them to EPAs in their program management software, but it's not the case that these are always actually observed as tasks, because these forms that are being used to assess competencies are more summative and longitudinal. So, for example, you might be, on your internal medicine rotation for 4 weeks, and this one form is filled in. There might be different faculty who contributed to that, but it's not necessarily clear that you actually observed performing taking history. 5 times during that experience. It really is more aggregate data, and it's more summative. So, and EPAs are a lot more formative. They're meant to actually be for learning and improving. So I do see this conflation between EPAs and competencies. And I think it might create a false sense of ability in terms of the task itself, because the task itself hasn't been documented in terms of that competence, right, or that performance in that task. So that's the thing, the trickiest space is that a lot of programs, I think, are assessing EPAs, but the link is actually, it's a direct link, but not an observable link, if that makes sense.
Right. And so there is a distinction between the two, and people often reach the finish line thinking that that is the EPA, whereas EPAs are more sort of along the path, right? Until someone is considered completely competent.
Well, I think they're almost parallel tracks,
They are.
right? So EPAs are composed of competencies, and they should include be linked to competencies. But I think that's the linkage in that direction, is the EPA should be linked to the competencies, not the competencies into the EPAs, and inferring that relationship. So
Okay.
you're trying to really kind of say, I saw you, make a souffle. I'm going to use cooking analogies because I'm obviously not a doctor. I am also not really a chef, but I know at least I can enter a kitchen without setting myself on fire. So if you think about something in terms of the souffle, like I've seen you make a souffle 10 times, and you didn't set your mise en place, you didn't bring your eggs to room temperature first, you didn't do these things, so you can't make it on your own yet. I need to help you. Right. So at some point you can say at the end, okay, you made a delicious souffle, you did all the right things, the output was exactly what expected. And that's the EPA. But the competencies are more about the person descriptors. So it's less about the task itself, and it's more about an observable ability. So it's thinking about content expertise, collaboration, communication, management, all these kind of knowledge, skills, attitudes, and values, versus the actual discrete how you do the task.
Right. That was a great explanation. Thank you for that, Sylvia. I would never have known the difference. So thanks for clarifying it. So then where can one actually start to figure out whether your EPA is actually an EPA?
Ooh, that's a good question, and it's trickier, I think, than it actually sounds. I would say that an EPA really should be observable and measurable. So it's something that can actually be seen in a clinical practice. This is really key. Even something like if part of your EPA is taking a history, and there's something around synthesizing patient information, that's really great, but you can get someone to talk to the thought process out loud, and then you can observe what they're thinking, and that's really kind of a key piece of, like, are you able to actually do this in a specific manner that's produces better outcomes. So I think you want to make sure that's something that can be observed and measured. You actually want to make sure you're actually integrating multiple competencies. So it's not just about medical knowledge in this case, or specific knowledge about the discipline itself, but you are actually also integrating things like communication skills and other things that are relevant to that task itself. I think whether it's relevant to practice, I think it's something that should be considered as well when you're thinking about an EPA. It really is about the practice. I've actually seen EPAs that were about things like presenting, and I think that for me felt like it was out of scope for an EPA itself, and it was really more about a different skill set is important, but maybe not part of an observable, measurable activity in clinical practice. So I'd like to see those kind of in a different space. And you also want to make sure these are things that the learner will be doing in future practice. So in UME, it's, I think, fairly straightforward. There's, I think, 12 to 13, depending on whose framework you're looking at, standard EPAs. But when you start getting to GME, those are actually, at this point, specialty specific. So the requirements for neurology will look very different than they would for pediatrics, for example. So you also want to make sure you're covering off those less frequent things in GME as well. You don't want to necessarily completely avoid them if they're not frequent. And then finally, if you're not sure, you can consult with educational experts or experienced clinicians to validate whether or not the task truly qualifies as an EPA. I think for UME in the US and Canada, it is fairly straightforward. They are fairly clearly outlined. But if you are outside of that area, then you maybe have more questions.
So UME and GME being undergrad and grad medical education, correct?
Exactly. So that's the undergraduate medical school and osteopathy as well. DO as part of that, just very similar curriculum, and graduate medical education. That's when everything kind of splinters off into its, I think, 70 plus specialty programs that are all very different in terms of their medical knowledge and requirements.
So, based on all of this, what changes do you recommend for improving how EPAs are measured in someone's curriculum or program?
Oh my goodness. I think, okay, I have so many feelings with this one. One of the biggest challenges, I think, is technology and its usage. And this is obviously near and dear to my heart, but utilizing a digital platform like 145 for real-time assessment tracking of EPAs is really critical. There's different ways that schools have gone about it. I know in some of the pilots run through the AMC, there was usage of things like survey software and Qualtrics. You start running into other issues that we'll talk about later when you're not using a purpose-built solution, but you want to consider your technology, you want to consider it being mobile friendly, which is helpful. But in my experience, EPAs are, even though they're actually meant to be assessed in the moment, and that's the idea kind of behind them, like I'm watching you do the thing and then I assess you and I fill in the form, we've actually seen that they're not often completed in the moment because of a lot of barriers in the moment. So if you're busy between patients, you're not going to take 5 minutes out to step in the hallway, give feedback, whip out your phone and do the thing. If you're in the OR, I suspect you're not going to be doing that in there either. There's also things like dead zones in the hospital. So if you're in radiology, you might not actually have a Wi-Fi signal to be able to pull up forms. So there's lots of barriers in that. And we found that what happens a lot is that they have the technology, it's mobile friendly, but they do it all at the end of the day. So that's one piece of it. I think you want to, if you're thinking about how EPAs are measured in your curriculum or your program, you want to consider the context. So I think it's really, really important. And one thing that I loved about how GME in Canada implemented EPAs was adding contextual questions. And that was really critical because things may vary, the outcome may vary depending on those contexts. So if you have something like your clinical setting, your patient complexity, you want to have those things potentially on your forms so that you know at the end of it whether that assessment was fulsome, whether it actually covered off all the different ways that that task could be performed that are critical. If you're looking at things, for example, between an ambulatory clinic versus an inpatient ward, those might be different kinds of conversations, different tasks, and those might look different in those different settings. A focused patient follow-up versus a new patient, history is going to look different as well. Mm-hmm. So you really want to make sure that you have those contextual variables covered off in the way it's meaningful for your program and your system. And I think you also want to just make sure you're keeping up on your EPAs and making sure that they're relevant and aligned with clinical practice. And I think especially for UME, I think it's more about the content than is about the overall structure of the EPAs. I think there's a lot of national bodies talking about which EPAs are relevant for undergrad. But I think in terms of what's in the actual assessment, I think you want to make sure those are still up to date and make sense to you.
So what in your opinion are the biggest hurdles in transitioning to using EPAs? Any suggestions on how to overcome these hurdles?
Oh my goodness. I think there's the biggest ones I think are like resistance in terms of your culture and your institution. We've heard from a lot of schools, especially on the UME side, where it's not mandated like it was in GME in Canada, where they're struggling to get their program directors, their clerkship directors, their faculty on board. And actually getting faculty on board was difficult in Canada as well. They kept asking, what's the validity of this? Show us the evidence. And it was really kind of trying to bring them on and do the faculty development required, get those workshops, get those seminars, and help educate those faculty with the benefits of EPAs. The trick to remembering that as well is that there's actually a few things I could go on about this one on a whole separate topic on faculty development, but a lot of faculty in these settings are really clinician teachers, they're frontline educators, they're not necessarily involved in curriculum design. So you have to make this really easy for them to action. And so if you think about the fact that they are, in a busy clinic, you don't want to send them, 50 forms to fill in a day. And gosh, if you are, you want to make sure they're really, really short and easy to complete. So
Right.
you want to make sure you're kind of buffering that cultural resistance with one, talking about the outcomes that are being supported and what the evidence is there, and then giving them ways to complete those things in a timely, efficient manner. One of my associate deans in a previous role was really excited when she learned that you could dictate narrative feedback if you're using your phone. And so that was a game changer, because that all of a sudden means like you wouldn't do it, but you could be in a coffee line and just dictate your comments. Don't do it; it's confidential. But you could do it anywhere essentially. So I
Correct.
think the cultural resistance is a big one. There's a lot of things that you could do to mitigate it. We could have a whole separate show on that just alone, and that's maybe we should. Um, but the other piece I think is resource constraints. So I think implementing EPAs requires training of your faculty. So that's one piece, and that does take time, effort, but also actually deals with all of the data that EPAs will generate. So having a great program management system can really help you there. Having a great analytics platform as well will help you there. But it really does, if you're actually doing EPAs, which are meant to be done regularly, frequently, and add up to a kind of a whole picture, you really want to make sure you have the programs to support that, both collection and getting you insights on that data. And I think in general as well, one of the kind of barriers that we run into is a lack of understanding about how to develop and implement EPAs. And that's how we kind of wind up seeing competencies linked to EPAs versus being true EPAs. And I'm going to use that term very loosely, but I think you can consult with your educational consultants. Most undergraduate programs have, undergraduate medical programs have, education consultants, curriculum designers. There's all sorts of people that you can talk to. You can also talk to us. Your client enablement managers are also wealth of knowledge. They can connect you with people in our company. We have lots of information on CBME, lots of experience implementing it. So I think those are the biggest ones, and they're not small. They really do require a lot of concerted effort, but I think the outcome is worth it.
Yes, absolutely. And so, obviously, good adoption of EPAs requires this effort, requires the time, but the benefits of, getting this right are immense. It means that you are putting the right, fully sort of, fully trained or fully knowledgeable health sciences professionals out there.
Absolutely.
Yeah.
I think there's one thing I actually would add as well. There's different ways to approach it depending if you're looking at UME versus GME. And I think one thing to think about too, in the UME framework, those EPAs are really, really valuable, because at the end of training, when you're applying to residency, those program directors should know that you can perform those 12, 13 tasks of the discipline on day one of residency. And those should be fairly standardized. So you should be able to look at any learner that's applying to your program and say, okay, I know you can come in without me having to recheck all of this. And so I think there's a really, that value at that transition point is really key as well, is that helps those residency programs be able to just move forward and get going come July 1st when all those new PGY1 start.
Yeah, yeah, so many benefits. So if you had to sort of summarize everything that you have told us, and essentially have three takeaways for program managers or directors on EPA, what would those be? And I think you have covered, some of those, but it would be great to just get a summary from you.
Oh my goodness. Okay. So I think the key pieces, I think, actually really are just two things that are really important. Okay, we'll see. Okay, I found it through. Okay, three things that are really important. The first two are get
Yeah,
your
fine too.
technology.
Two is fine too.
Well, I hit 2.5, and I realized that the second one was actually kind of two separate points. So I think there's one thing we talked about, the faculty development. I think without that, you are absolutely dead in the water. You have to have your faculty on board. Obviously, your students would also should also be on board, and to understand what outcomes it's supporting. You want to try to find a balance of that to make sure that you're not overburdening your faculty or your students. So I think that's really key. But I think doing the faculty development, doing it well, will prevent a multitude of problems down the road. Making sure your technology can keep up with you, make sure that you can collect the data and report on it in an easy way is going to save you a lot of headaches. So those are the two really main things. And I think I actually have written about this before in the past because I'm so passionate about those two things. But the third one that's kind of a offshoot of the faculty development is consider your actual entrustment scale and what you're using. So one thing we didn't really dive into, and we could go on for hours, and I won't, I promise, is that entrustment is incremental. And so part of the faculty development is making your faculty comfortable with the idea of entrustment and telling them that, you're not entrusting that learner. It's going to be made by another committee who's going to look at all the data and decide whether that learner is entrustable. But one of the places on the faculty dev side, I think, where there's a struggle is entrustment scales themselves. So I think at this point, there's probably 4 that are widely used in terms of the assessment scale used on an evaluation form. In Canadian GME, they've settled on the O score, which is the Ottawa scale, and it starts from I had to do to I didn't need to be there. And really kind of the idea of kind of passing the threshold for being entrustment, to consider for entrustment, is this idea of like, I needed to be there just in case, or I didn't need to be there. And that works generally okay in medical education, in graduate medical education, less so in surgery, because I think they're a little bit hesitant about not being in the room. But that also then translates to UME, where they're always going to be in the room, right? You're not going to leave those medical students as clerks alone. So a lot of undergraduate medical programs have shifted to a modified Chen scale, which is a little bit different, because the highest end of that scale is you go ahead, I'll double check your key findings, right? So it's less about entrustment in that strict sense. Like, it's not saying I didn't need to be there, which helps faculty a lot in terms of feeling comfortable. So I think it's both part of faculty development, and then it's also kind of its own offshoot, because it's its own piece of the puzzle.
Right. Yeah, that's so great. Like, thanks for bringing it all together for us, and thanks for all this great information, Sylvia, and your time. The time that you took to be here with us, and thank you all for watching and listening. And we will catch you in the next episode. But before you go, if you haven't already subscribed, please go ahead and do so. You can also go to our website to get more information on Acuity Insights. Our website is acuityinsights.com, and you can also sign up for our newsletter from there, or our blogs. And so with that, we will see you again. Thank you. If you like this episode, please be sure to check out a couple other episodes, one on reducing demographic differences in admissions, and another one about MSPE and making your process a lot more efficient. And if you haven't subscribed, please be sure to do so. Thank you so much, and we'll see you next time.